Hi, I'm Emily Bond. Most of you have met me already. I'm the PCN pharmacist for Strawberry Health. My role across the PCN is to work with the PCN team and look at particular areas where we can improve within the PCN. Areas of chronic disease that use a lot of practice resources and might lead to increased admissions to secondary care. And it's very much about bringing new eyes to the services we offer, working out how we can work with the other PCN stakeholders such as community pharmacy, community nursing, local primary care specialists. And there's a big emphasis on using technology to improve patient care and to optimise the resources that we have as a PCN. So example, when coronavirus hit, one of the areas that I decided to look at was identifying warfarinized patients who would benefit from switching to a DOAC, particularly housebound patients who were going to struggle with phlebotomy access and increased risk of contracting COVID. Because of course DOACs require less monitoring, less surgery visits, the dose is relatively consistent, concordance can be enhanced if it needs to go into an MDS, etc. And the risks of intracranial hemorrhage is much lower, so for the right patients, this is a sensible drug swap. Of course, it needs to be an informed patient-centred decision, which takes a little bit of time to go through the benefits and the risks with each patient and understand their ideas, concerns and expectations. So from the initial search, there were approximately 300 patients identified across the PCN between Homewell and Vine who needed consideration. So the initial clinic cohort was 84 patients to get me started, and approximately 50% of those patients that we looked at consented to being switched over to the appropriate dose of DOAC subject to kidney function, etc. So if we extrapolate this data to the total 300 patients and assume that the average switching patient is going to go from having blood tests every 2 to 3 weeks to every 6 months or so, then we have an opportunity to save over 2,000 PCN appointments over a year. And although the stroke reduction risk is broadly similar for warfarin and DOACs, we have an opportunity to reduce risk of intracranial hemorrhage by approximately half. And so I think it's a beneficial project, both in terms of making use of the resources, but also improving patient safety, reducing risk of more mortality. Going forward, there are a lot more improvement projects I'd like to look at, including use of SGLT2 inhibitors in patients with diabetes, and using low-carb education and digital platforms to support our diabetic patients in the first 5 years of diagnosis.